Look at your hands right now, not later, not the next time you happen to glance down. Right now, in this moment, before you read another sentence, hold them out in front of you with your palms facing down, and look at your fingernails the way you have probably never looked at them before. Not for polish, not for length, not for cleanliness, but as a diagnostic surface. What you are about to learn is that the nails on your fingers are not cosmetic structures. They are physiological windows, thin, translucent extensions of the cardiovascular and circulatory systems running through your entire body. And for adults over 60, they are sometimes the first visible, externally observable place where a deteriorating heart broadcasts a warning that every other monitoring system in your body has failed to deliver clearly enough to hear. Doctor. Varen Summers, professor of medicine at the Mayo Clinic and director of research at the Center for Sleep Medicine, whose work on cardiovascular physiology and peripheral circulation has been published in journals including Circulation and the Journal of the American College of Cardiology, has written about the clinical value of peripheral markers in older adults, the observable signs on the skin, the eyes, and the extremities that experienced cardiologists are trained to assess before a single diagnostic test is ordered. The nails are among the most information-dense of those peripheral markers, and yet the conversation about what specific nail changes mean, which ones require urgent evaluation, and which ones are being silently dismissed by millions of adults over 60 as ordinary aging, has never been delivered directly to the people standing in front of their bathroom mirrors every morning who need it most. There are 4 specific nail findings that cardiologists are trained to look for in older adults. Each one is linked to a distinct cardiovascular mechanism. Each one has a clinical name, a documented physiological cause, and a population-level prevalence in the 60-plus age group that makes this information far more urgently necessary than it has ever been. Stay with everything that follows because the goal is not to frighten you about your hands. The goal is to give you the observational vocabulary that turns a routine glance at your fingernails into something that might, for some people hearing this, prompt a conversation with a cardiologist that changes the trajectory of what happens next. The reason fingernails can reveal anything meaningful about the heart at all comes down to a physiological relationship that most people are never taught. And understanding it is the foundation on which everything that follows depends. Your fingernails grow from a matrix of rapidly dividing cells at the base of each nail, and those cells require a constant, precisely regulated supply of oxygen and nutrients delivered through the dense network of capillaries, the microscopic blood vessels that form the most distal branches of your cardiovascular system. Running through the nail bed, the tissue sitting directly beneath the nail plate itself. This capillary network is part of the peripheral circulation, the farthest reaches of the cardiovascular tree, and it is exquisitely sensitive to changes in central cardiovascular function. When the heart's output is compromised, when oxygen saturation in the blood falls, when clotting dynamics shift, or when inflammatory processes begin affecting vessel walls, those changes are reflected in the nail bed, in its color, its shape, its texture, and in the structural appearance of the nail plate growing above it, in ways that are visible to the naked eye without a single piece of medical equipment. Dr. William Roberts, editor-in-chief of the American Journal of Cardiology for over 3 decades and one of the most published cardiovascular pathologists in the history of the specialty, has documented extensively in both postmortem and clinical research that peripheral vascular changes consistently precede or accompany central cardiac pathology in ways that are systematically underused as diagnostic cues. Your nails are not the heart, but they share the same blood supply, respond to the same hemodynamic pressures, and for adults over 60, whose peripheral circulation is already less elastic, whose capillary density has declined, and whose cardiovascular reserve is narrower than it was at 40. Those responses become visible faster, more dramatically, and more clinically meaningfully than they would in a younger adult. This is why nail examination is on the checklist of every experienced cardiologist, and this is why what you are about to learn about 4 specific findings has never been more relevant to the decade of life you are in right now. The first warning sign is the one with the longest medical history and the most clinical documentation, and it is also the one most frequently dismissed by patients as nothing more than an unusual nail shape that runs in the family. Nail clubbing, a gradual process in which the fingertip enlarges and the nail curves downward around it, creating an angle between the base of the nail and the skin at the cuticle that progressively flattens and then reverses, is not a cosmetic variation. It is a documented physiological response to chronically reduced oxygen delivery to the peripheral tissues, and it has been associated in peer-reviewed literature with a range of cardiovascular conditions, including congenital heart disease, infective endocarditis, pulmonary hypertension, and chronic heart failure with reduced ejection fraction. The mechanism is straightforward but almost universally unknown to patients. When peripheral tissues receive less oxygen than they require across months and years, the body attempts to compensate by increasing the density of capillaries and soft tissue in the fingertip, and that process, repeated daily, relentlessly, as the body tries to solve a problem it cannot name, produces the visible enlargement and curvature that defines clubbing. A systematic review published in the American Journal of Medicine, examining hundreds of patients presenting with nail clubbing, found that in adults over the age of 60, cardiovascular or pulmonary pathology was identified as the underlying cause in the clear majority of cases evaluated. The critical clinical point is this: clubbing develops slowly across months, and because it happens gradually in a set of hands that belong to someone who sees them every day, it is almost never noticed by the person experiencing it until the change is already advanced. If someone in your life, a spouse, a child, a friend, has commented that your fingertips look different than they used to, if your nails seem to curve more than they once did, or if the angle between your nail and the skin at the cuticle has visibly changed, this is not a feature of ordinary aging, and it is not something to add to the mental list of things to mention eventually. The second warning sign is the one that cardiologists consider most immediately alarming when they observe it during an examination, and it is almost certainly the one you know least about. Splinter hemorrhages, thin, dark brown, or reddish-black vertical lines running beneath the surface of the nail, resembling small splinters trapped under the glass, are caused by tiny bleeds within the capillary network of the nail bed. Minor trauma to the hand can produce one or two of them on a single nail, and in that isolated context they are generally benign. But multiple splinter hemorrhages appearing across several nails simultaneously, or splinter hemorrhages appearing in someone with no history of specific hand injury, are a recognized clinical marker for conditions that require urgent cardiovascular evaluation, rather than watchful waiting. Infective endocarditis, a bacterial infection of the inner lining of the heart, most commonly affecting the heart valves, is the condition most directly and consistently associated with multiple spontaneous splinter hemorrhages in the clinical literature, and it is one of the conditions for which nail findings are listed as peripheral diagnostic criteria in the Duke criteria framework used by cardiologists worldwide. The American Heart Association has documented that endocarditis, untreated or delayed in treatment, carries mortality rates that make it among the most dangerous infectious cardiovascular diagnoses in older adults, and that recognition of peripheral signs, including nail hemorrhages, is critical precisely because the early symptoms of the condition, fatigue, low-grade fever, vague malaise, so consistently mimic dozens of less serious illnesses that the cardiac origin goes unrecognized for weeks. Beyond endocarditis, research published in the Journal of the American Academy of Dermatology has identified associations between multiple splinter hemorrhages and antiphospholipid syndrome, a clotting disorder that significantly elevates stroke and venous thromboembolism risk, as well as vasculitis and systemic embolism. If you have lines under your nails that you have attributed to impacts or injuries you cannot specifically recall, and if those lines appear across multiple fingers rather than one, the appropriate response is to photograph them in natural daylight today, note the date, and contact your physician this week, not at your next scheduled appointment, and not after you have finished watching what you were going to watch next. The third warning sign is one that a substantial proportion of adults over 60 have already seen in their own hands without knowing it carried a clinical name, and without knowing that what they attributed to older skin or poorer circulation represents a documented marker for a specific cardiovascular condition with a specific physiological mechanism. Terry's nails, a condition in which the overwhelming majority of the nail appears white or uniformly pale, with only a narrow band of darker pinkish tissue visible at the very tip, were first formally described in medical literature by Dr. Richard Terry, a British physician who observed the finding consistently in patients with liver disease and advanced heart failure, and published his observations in a case series that drew the clinical world's attention to nails as cardiovascular indicators. Subsequent research expanded the documented associations to include type 2 diabetes, chronic kidney disease, and hypoalbuminemia, low protein levels in the blood that occur in advanced heart failure when the heart can no longer maintain sufficient circulatory pressure and fluid begins leaking from blood vessels into surrounding tissue, producing the pallor visible through the nail. A study published in the Archives of Internal Medicine found Terry's nails present in a clinically meaningful proportion of patients with confirmed congestive heart failure, and the degree of nail pallor correlated with disease severity in a way that made the nail finding a rough proxy for the underlying hemodynamic compromise. Even without the specific Terry's pattern, a generalized paleness of the nail beds, a loss of the healthy pink tone that should be visible through the translucent nail when you press briefly on the nail and release, can indicate iron deficiency anemia, which in older adults is frequently a symptom of gastrointestinal bleeding, chronic kidney disease, or malabsorption, each of which places an additional and often unrecognized burden on a heart already managing reduced capacity. If your nails are pale across most of their visible surface, not just at the very tip, not just in certain lighting, but consistently, noticeably paler than the nails of another person your age, the correct response is not to conclude that this is simply how your hands look at 65. The fourth warning sign creates a connection between two things that the 60-plus population encounters extremely frequently: cardiovascular stress events and changes in nail texture that almost no one has been explicitly taught to link together. And the failure to make that connection means that a biological record of a serious cardiac event is being walked past in bathroom mirrors across millions of households every single morning. Beau's lines, horizontal ridges or grooves crossing the nail plate from one side to the other, running perpendicular to the direction of nail growth, represent a temporary but measurable interruption in the cellular activity of the nail matrix, caused by a systemic stress event severe enough to pause nail growth for a period of days to weeks before it resumes. The conditions documented in clinical literature as sufficient to produce Beau's lines include severe systemic infection, major surgery, chemotherapy, and myocardial infarction. Research published in the British Journal of Dermatology has documented Beau's lines appearing across patients following confirmed heart attacks, and because nails grow at a predictable rate of approximately 3 millimeters per month, the position of the groove on the nail plate from the cuticle can be used to estimate the approximate timing of the event that caused it, making the nail a biological timestamp of cardiac stress that the body recorded even when the event itself was not fully recognized. Beyond acute events, Beau's lines have been documented in association with severe hypertension crises, episodes of acute heart failure decompensation, and significant peripheral arterial disease. If you have noticed a horizontal groove or ridge crossing most or all of your fingernails that appeared at roughly the same time several months ago, as opposed to a single nail affected by a knock or injury you remember, and if that appearance coincided with a period of unusual illness, hospitalization, or severe physical or cardiovascular stress, the groove you are looking at may be your body's only remaining physical record of a cardiac event that your medical file has never acknowledged. There is one more dimension of this picture that belongs specifically to the large proportion of adults over 60 who are already managing cardiovascular conditions with daily medications, and it involves a diagnostic interference problem that creates real clinical confusion. Several of the most commonly prescribed cardiac medications directly affect nail appearance in ways that can mimic the warning signs described above, or mask them in ways that make accurate assessment more difficult. Anticoagulants, including warfarin and the newer direct oral anticoagulants rivaroxaban and apixaban, prescribed to millions of older adults for atrial fibrillation and clot prevention, can produce spontaneous splinter hemorrhages and nail bed bleeding even in the absence of the underlying pathology those findings are meant to signal. Beta blockers, including metoprolol and carvedilol, prescribed for blood pressure, arrhythmia, and post-heart attack protection, can reduce peripheral blood flow enough to produce nail bed pallor that resembles the pallor associated with Terry's nails or anemia-driven cardiac strain. And statins, the single most commonly prescribed class of cardiovascular medications in the world, have been documented in case reports in the Journal of the American Academy of Dermatology as causing nail changes including brittleness, discoloration, and in rare cases onycholysis, a separation of the nail plate from the nail bed beneath it, in a small but real subset of patients who may not connect those nail changes to their cholesterol medication. None of this means any of these medications are wrong for you. It means that when you bring your nail findings to a physician, you must simultaneously bring a complete and current list of every medication you take, because the interaction between cardiovascular pharmacology and peripheral nail findings is precisely the kind of clinical nuance that disappears in a 7-minute appointment when a patient holds out their hand without the medication context already on the table and in the record. Here is what to actually do with everything you now know, because awareness without a protocol is just a longer version of worry. Begin with your hands in good natural daylight, not a yellow overhead bulb which will distort color assessment, and examine each nail systematically for the 4 findings. Downward curvature with fingertip enlargement for clubbing, vertical dark lines for splinter hemorrhages, uniform pallor across the nail surface for Terry's nails, or anemia-related pale beds, and horizontal ridges crossing the nail plate for Beau's lines. Photograph any finding you are uncertain about against a white background in natural light, and write down the date you first noticed it, because timing is clinically relevant in every one of these conditions. If you find multiple splinter hemorrhages across several fingers that you cannot attribute to specific remembered trauma, contact your physician this week and use the words infective endocarditis when you describe what you are seeing, because that specific phrase will ensure your concern is received at the level of clinical urgency it requires. If you have Beau's lines that appeared across multiple nails simultaneously around the time of a period of severe illness or cardiovascular stress, bring that observation and that timeline explicitly to your cardiologist and ask for it to be addressed by name in your record, because a cardiac event that your body documented and your physician has not formally evaluated is an open clinical question that deserves a closed answer. And if you are already on anticoagulants, beta blockers, or statins, flag your medication list before any nail-related discussion begins, because the conversation has to start with what you are already taking before any finding can be correctly interpreted. Your nails have been carrying information for months or years. The record was always there. What was missing was the knowledge to read it for what it actually is. And now you have exactly that.